Hello and welcome to this episode of Clinical Minute. I am your host, Maria Berrocal. Today, I'm joined by Dr. Nemo Patel, whose recent research asked whether secondary IOL implantations are profitable under current Medicare reimbursement rates. Dr. Patel, thank you so much for joining me.
Thank you for having me.
So tell us what your findings were.
So yeah, we did this study mainly to look at how the reimbursement rates are affecting secondary IOLs and if they're profitable under our current operative times. So we looked at both IOL repositioning, IOL insertion, and IOL exchange, and then we took our operative times, and then we used a methodology to look at the costs and then also the CMS reimbursements.
So
what we found was when you look at the reimbursement relative to the cost,
so basically I'm going to just ask you
85% of all those procedures were unprofitable, and the net margins were actually about negative $3,000 per case. So that was kind of an interesting finding to realize that some of the surgeries we're doing are potentially actually losing money unless you can do them extremely fast.
Oh my goodness, yes. We all seem to know that because we don't really have IOLs that are designed specifically to be placed without any capsular support. So we have to do all these contrived procedures that take a very long time. So what do you think can be done to address this issue?
Yeah, I think it's going to take quite a few different efforts. This is, I think, is one paper, one part of the story on retina surgery in general. So we actually partnered with the ASRS Health Economics Committee, who's been pushing some of this agenda across various types of surgery. We have similar studies on pediatric surgery, scleral buckles, retina surgeries, looking versus cataract. So and I think it's building a story and evidence that we can take it back to policymakers to see if we can at least increase reimbursements or increase the time that they're saying that we should take on these procedures. Some of them are very complex, and that's why we're being referred them. But they're not easy to do in the time that requires for them to break even for the hospital. And I think the issue with that is really it's hurting patient access because they're not overly profitable. There's a lot of doctors who don't want to do them. And then patients who need them, where they have almost no vision in the eye with no lens, they're having a long wait time for surgery. Some of them are having to go out of network. So I think there's a real need to have advocacy for the policymakers to help the access on this front.
No, I think this is very important because we're seeing that with surgery centers not wanting people to do long cases, and then the patients are the ones who are affected by all of this.
What a great introduction.
Yeah, we're hoping that basically the surgery centers can become more profitable retina and we can get more access into these areas because it's very difficult to move patients to the hospital setting, especially if you don't often operate there. If you're in rural areas, they may not even have all of the equipment that's required for these cases. So it's really important to be able to do these cases in areas that we're used to operating in for patient safety and quality.
Well, thank you so much for your advocacy in this and for the ASRS for really partnering in this very important issue.
Yeah, and I'd also like to think a lot of this work was done by one of our Harvard medical students, Sam Hoffman, and one of our residents, Sydney Nimesh. So they were the ones who really did the grunt work and did a lot of the calculations. So also thank you to them.
Well, thank you, Dr. Patel, for examining this overlooked question. We'll be back soon with another key paper and another expert voice. Until then, this is Maria Berrocal signing off from Clinical Minute.